Good afternoon to everyone that is joining us. I would like to welcome you all to the first of a series of webinars called The Color of COVID. This is the first installment of this series, brought to you by the Institute for Healing Justice and Equity at St. Louis University. I am Keon Gilbert. I'm an associate professor at St. Louis University in the College for Public Health and Social Justice, and also a co-director of the Institute for Healing Justice and Equity. Next slide. This series is subtitled Stopping the Trend. As we have noticed, Black Americans are dying at higher rates compared to others diagnosed with COVID-19 or the coronavirus. This disparity points to systemic inequalities related to neighborhoods, housing, access and use of healthcare services, and the burden of chronic disease within Black communities that we are very well, that we all know much about. But what we want to do today is really to talk about the relationship between those disparities and this particular pandemic. We have gathered scholars, activists, and community leaders that will discuss the existing inequalities that contribute to the longstanding health inequities and the relationship to COVID-19. We also want to make sure that we spend some time outlining solutions and action steps that can be taken to stop this trend. Our panelists today include Melody Goodman, Rashawn Ray, Rakaya Yerby, Brian Smedley, and Oliver Brooks. Next slide. Really quickly, the Institute for Healing Justice and Equity at St. Louis University is co-founded by Kira Banks, myself, Amber Johnson, and Rakaya Yerby. Our program director, Michelle Rossmeyer, is our webinar guide for today. We want to thank her for helping to pull this together and working out all of the logistical aspects of this as well. We have our contact information here if you would like to reach us. The Institute for Healing Justice serves as an institutional center at St. Louis University to focus on addressing systemic oppression and the disparities that arise from systemic oppression and structural racism. We are engaged in training, capacity building, as well as evaluation and assessment to help our university and our larger St. Louis community to improve the capacity and our reach to be able to address systemic health issues within this region and nationally. Next slide. Today's format includes, we'll do a quick introduction of each panelist. We'll spend a little bit of time speaking with them about some of their work and what they're doing to address COVID-19, and also we'll open up the chat room for questions and answers. We ask that you try to put the questions in the chat feature. There is also a Q&A feature. You can use that, but we would like for you to use the chat feature more so. We will try to address those questions at the end. We have developed a few questions, and the questions that you submitted prior to during the registration period. We will use those to help guide some of our discussion before opening up the chat to questions and answers. And next slide. Our first panelist is Dr. Oliver Brooks, who is the current president of the National Medical Association. He also serves as the medical director at Watts Healthcare Corporation in Los Angeles. His staff appointments include Centinela Hospital in Inglewood, and at the Martin Luther King Community Hospital in South Los Angeles. He is also vice chair of the OB Pediatrics Department and is a member of the executive committee. He's also chairman of the Community Clinic Association of Los Angeles. As you can see below, there's some his social media handles as a way to reach him after this webinar. And we'll turn directly to Dr. Brooks. And one of the things that I'd like to start with, Dr. Brooks, is if you could give us an understanding of why this pandemic is particularly unique and how is it affecting African Americans in particular ways.
Thank you very much, Keon, Mr. Gilbert, Institute for Healing Justice and Equity. It's a very good question because I think we should start from the beginning. So SARS-CoV-2 is the virus, the disease is COVID-19. It's a virus that came out of China. It's infectious. So giving an example, there's something called an R naught, which is how infectious something may be. So the R naught for COVID-19 or SARS-CoV-2 is about 3. Okay, that's relative infectivity. So for influenza, it's 1. For measles, it's somewhere between 12 and 18. For whooping cough or pertussis, somewhere about 10 to 12. So what's the difference? We have a vaccine for influenza, pertussis, and measles. So that's why we're not seeing widespread infection with those conditions. We are seeing widespread infection with SARS-CoV-2, COVID-19, because honestly, it's very infectious and we don't have a vaccine. It's a very serious condition. Right now in the United States, there are approximately 1 million confirmed cases with about 57,000 deaths, so about a 5.7% mortality rate. Now, testing is a concern, we've all heard it. Likely, the good news is the actual mortality rate is much lower because we have confirmed 1 million cases, but there are probably many, many more cases out there that we haven't confirmed. But probably most of the deaths have been confirmed, though not all. So the mortality rate will likely drop. That's the good news. The bad news is we don't have enough testing. So at this point, this country has tested only approximately 1.5 to 2% of the population. We don't really have a good handle on it. So that's the virus, COVID-19. So let's look at it in the African-American population. So we are seeing is from New York to Chicago, to Milwaukee, to Detroit, to New Orleans, to LA, across the country, higher rates of hospitalization and death among the African-American community. I would say nationally, it's probably at around 2.5 times. So you can look at it and it's higher in some places than others, but overall it is higher. We have good data. No, I take that back. We have some data, but we don't have great data. That is a challenge. Now let's look at the African-American community. And you mentioned it. There are, in my mind, what I see is a toxic admixture of 3 primary elements that together weave a fabric of higher rates of outcome, of poor outcomes with African Americans. And unfortunately, this is not a fabric you can use to cover your cough, cover your mouth. So, and in no particular order, let's start with pre-existing conditions. What I've been hearing people say is comorbidities, but I like the term pre-existing conditions because that's more relevant. So the CDC has found is what puts you at highest risk for hospitalization and death. Number 1 is age. So that every one of you on this panel has a pre-existing condition called age. That you cannot control. The other pre-existing conditions that we're looking at first is hypertension. That's the one that is the highest rate of adverse outcome. African Americans are 20 to 40 times more likely, 20 to 40% more likely to have hypertension. Let's look at diabetes, the next one. 2.2 times more likely to have diabetes. Obesity, 30% more likely to be obese. And then moderate to severe asthma is also a problem. So these things put us at risk for pre-existing conditions. Let's move to the next one, social determinants of health. So we suffer disproportionately from social determinants of health. I'll give you a couple of quick examples. Income. The net worth of a white family in the United States is approximately $171,000. The net worth of an African-American family is somewhere around $20,000, so approximately 10 times less. It's called the wealth gap. I call it the health gap. Insurance. We are uninsured at a rate of 9.4%, the white population 5.7%. So we're about twice as likely to be uninsured. So these are real. Poor insurance rates or poor insurance coverage leads to poor health care. And then you look at jobs. We tend to work in the jobs that are out there with exposure. So even if you have no hypertension, no diabetes, and you're young, you're out there working in the service industries such as janitorial, security, food service. So you are exposed, so you're just more likely to get the virus. And then lastly, and we can't get away from it, is racism. This country has a 400-year history of racism, okay? So when you do studies, and these have been done, NMA has been dealing with health equity and adverse outcomes, disparate rates of diseases for decades. This is nothing new to us. So if you factor out income, education, and insurance, if you remove those as factors, still Blacks have higher rates of disease and adverse outcomes. So the key is race is an independent factor. It's just not that Black folks may be poorer or have worse jobs or less health care. Race in and of itself leads to poor outcomes. I think that's kind of an important fact for people to understand. There's implicit bias, and there are a lot of reasons that cause that. So we at the NMA are working in all those arenas. I, as president, am speaking to these things, ensuring that our people know the facts and do what they can. Get yourself healthy. If you have diabetes or hypertension, get it under control. Advocate for yourself. We have a referendum coming up in 6 or 7 months. So look at positions and make your decisions, and partner with like-minded organizations. We have a manifesto with Rainbow Push organization to ensure there's testing, prevention, look out for vulnerable populations like those in the prisons. So this is our approach at the NMA. So I basically laid out how we see it at the NMA, how I see it. I'm a practicing physician, pediatrician. So I understand exactly what's going on out there to the best I can, because we don't know as much as we know. There's more unknown than known.
Okay. Let me just ask one follow-up question in terms of thinking about some of the roles that physicians are playing, in particular Black physicians, either through the NMA or other professional associations. What has been some of the responses from them, as well as thinking about how they are sort of experiencing this in terms of burnout, work-life balance, increased susceptibility to them as healthcare workers, healthcare practitioners?
So that's a good question, because I think that's a little misunderstood sometimes from the news. Okay, there are the frontline workers. Okay, those are in the ER, those that are EMTs, the nurses, and they have direct patient contact on a routine basis, persistent basis with patients who are known COVID positive. So they're literally risking their lives. Okay, you got 2% are going to die, let's say, no matter what. So there is clearly burnout. There's something I call general anxiety disorder, which is a diagnosis, where as physicians are just worried in general that, and it's even not for ourselves. You were just going to take it home to your wife or to your in-laws, to your children. So there's that general anxiety. And then there are also those that, like me, I'm at a health center, I'm chief medical officer at Watts Healthcare Corporation. So we're not seeing a whole lot of really, really sick people, but we're still very concerned. Our volume is down. So we're doing more telehealth now. The solo and small group practitioners, which a lot of African-American physicians are also seeing less patients, and their practices are actually being threatened economically. So I presume you'll address some of the economic concerns on this particular webinar. So there's the economic stress, there's the stress of taking care of sick people, and then there's the internal stress of what's going on inside of themselves. So there are many ways to feel burnout, and we are feeling it, but we're physicians. This is our life.
Okay. Thank you so much. We're going to come back to some of those issues. I'm going to turn to Melody Goodman to talk to us a little bit about some of the emerging data that we're seeing, and to discuss some of the gaps. I'm sorry, I forgot to introduce you. My apologies. My apologies. We have Melody Goodman, who's an associate professor at New York University School of Global Public Health. Also, she's the associate dean for research. Her areas of expertise include identifying origins of health disparities, evidence-based primary prevention strategies, measurement of health disparities, and we colloquially call her the Beyonce of biostatistics. So please welcome Dr. Goodman, and I'll turn to you.
Yeah, I think the data piece is really hard because we don't have standardized data collection. I really thank Milwaukee for releasing race data first, and that's partly because they put racism as a public health issue in their county health department. And so they've been ahead of the curve in terms of addressing everything as an equity issue. But the nice thing about peer pressure is once one locality does it, it sort of pressures other localities to do the same. I'm a little bit cautious though of where people are pulling data from. And some of the data that I've seen from New York City has as much as almost half of the population with missing race ethnicity. So yes, the trends we're seeing are true, but they're not based on the majority of the cases that we're seeing. And I think this really speaks to the disinvestment this country has made in the public health infrastructure over a course of many, many years. And now is the time where we need that infrastructure, and it really just does not have the capacity to do everything we want it to do. And so I hope at least one of the things that comes out of this is that we really decide to make a real investment in both our public health infrastructure, but also public health science. Everyone wants to know when they can go back outside. Wouldn't it be great if we had the answer to that in advance and we just, don't know? But I do think the data is going to be key. And I also think how people model the data is going to be key. So we've been relying a lot on IHME's model, which comes out of Washington, but a lot of their model is based on mortality data. And that's really only one part of the picture. And I think that's partly why we've seen the estimates change so much from day to day and as situations change. And I also think it's partly why we have not been able to estimate the impact that physical distancing has done to sort of flatten the curve. So I hope I answered your question. But the answer is we need more data, essentially. We need more systematically collected and standardized data.
Yes, you did answer the question. So a quick follow-up question. In terms of talking about missing data and why in general is race such a difficult issue in terms of collecting data and especially in public health spaces?
I don't think it's that hard. Race is a challenging issue because it's an American man-made social construct. And there's lots that we can talk about what that means. But to be able to collect data by race, to me, is the equivalent of being able to collect data by age or gender or any of the other standard demographic characteristics that we have. There are some populations where race doesn't make sense, particularly if you weren't born in the US and you don't understand how we sort of racially stratify populations, but it should not be that 50% of race ethnicity data are missing. Especially because a lot of this is reported on death certificates and other sort of forms of administrative data, especially since we've particularly moved to electronic health records. And I know lots of hospital systems are including race, ethnicity, gender, other demographic characteristics along. Some of them are also including some social determinants of health data. So I don't really see this as a challenge to do. I see it as a matter of political will, whether it's something we want to do and something we value doing in terms of how we allocate our time.
Okay, just so another quick follow-up, and this will be a segue to Rashawn, talking about some of the data in terms of geographical dispersion. And so when we look at some of this data, thinking about where many of the cases are in sort of the higher rates of mortality, talk to us about where some patterns that you were seeing.
So I think, it's sort of the things that people will expect where there are denser situations. And I think people think about density in terms of housing, but what we're seeing in the Midwest is density in terms of employment. So any place that someone is going to be in close proximity to another person, whether you live in New York City like me, where we all live on top of each other, or you work in a meat plant where you're standing a few feet away from each other, I do think that is part of the reason. I think the disparities are caused because when we classify people as essential workers, we've classified lots of jobs that are traditionally occupied by Black and Brown residents of our country as essential workers, people who work in grocery stores and pharmacies and work on transit systems, people who deliver food, do Uber Eats and all the like. They've all been classified as essential workers. And then if you think about you live in a household that's really dense. So one of the things they were saying was use a separate bathroom. Everyone in New York would kill for another bathroom, right? Like what we wouldn't do for another bathroom. But most people don't have the ability to use a separate bathroom or a separate kitchen from someone else. So if one person in your house is an essential worker, it's like everyone in your house is an essential worker. If they're going out, they're at high risk, they're coming back home. And so what we're seeing in terms of hotspots are lots of people who are living in dense situations, who even if they're not a frontline worker, someone in their household is, and it's putting them at higher risk.
Great, thank you. Thank you so much. Now I'm going to turn to Rashawn Ray. Michelle, can you pull up his, yeah, thank you so much. Rashawn Ray is an associate professor of sociology and executive director of the Lab for Applied Social Science Research, LASER, at the University of Maryland in College Park. He is currently serving as a David M. Rubenstein Fellow at the Brookings Institute. His areas of expertise include addressing the mechanisms that manufacture and maintain racial and social inequality, with a particular focus on police-civilian relations, men's treatment of women. His work speaks to the ways that inequality may be attenuated through racial uplift, activism, and social policy. Also, you'll see his Twitter handle at Sociologist Ray down below. And we'll turn to Dr. Ray with a quick question of, so Ray, this should not be expected in terms of looking at the disparities that we're observing in Black communities. Why has this been such a shock, and why is it taking us so long to respond?
Yeah, I think that's a good question. Well, first off, Keon, thank you for having me on. I think you've assembled the best people, so kudos to you and your center colleagues. I think that your center is going to have a big impact in St. Louis and across the country by assembling these experts. I think you have some of the best people here. You know, I think for most of us on here, it's not a surprise at all. And one big thing that I've been saying is that we've been taking, and we being the United States, has been taking a colorblind approach to an issue that's not colorblind. And one big saying that I think that most of us know that has been throughout generations is that when America catches a cold, Black people catch the flu. Well, in 2020, when America catches COVID-19, Black people die. And I think part of that has a lot to do with structural conditions that undergird these pre-existing health conditions that Dr. Brooks was talking about. And I think it's important to lay that out. So Dr. Goodman just talked about some of these, the way that Black people are more likely to live in densely populated areas, but that's not always the case. So we look in the Midwest, for example, it's about work. So some of the analyses I've done at Brookings, looking at some of the first states to release racial data, Michigan, Wisconsin, Louisiana, Illinois, we see that Blacks are about 4 times more likely to die from COVID-19. Now, of course, across the nation, it's going to probably be, as Dr. Brooks was saying, around 2.5%. That is still astronomical. And so part of the reason why this is happening has to do with our structural locations. Predominantly Black neighborhoods are drastically different in terms of resource allocation than predominantly white neighborhoods. The reason why is this has roots in the legacy of redlining. So you can take cities across the country, Baltimore, Chicago, Washington, D.C., Detroit. You could take a map from 100 years ago and look at it by race and class and overlay it with that map from today. And you'll see that they are almost synonymous in terms of where people are living. So part of what that means is predominantly Black neighborhoods are less likely to have access to healthy food options. What does that mean? That means fewer grocery stores, fewer places that have fresh fruits and vegetables. One big saying that I've been telling people as people try to blame Black people's behavior, you know, that's always a go-to when we talk about why we see disparities, partly because structure is difficult to see, and oftentimes all of us are complicit in structural racism. So admitting that is something difficult to do. I always ask people, if you have $10 in your pocket and you're trying to feed a family of 4, are you going to go to the Whole Foods that doesn't exist in your neighborhood, or are you going to go to the McDonald's on the corner? I think most people are going to go to that McDonald's. The other part also deals with access to places to engage in physical activity. Black neighborhoods have fewer recreational facilities, fewer parks, less lighting. Of course, we talked about work, but part of thinking about work is the fact that Blacks represent about 20 to 25%, as well as Latinos represent a very high percentage of people who are working these quote unquote new essential jobs. People are out working for pennies on the dollar, putting their lives on the line. So I think part of thinking through this is that these structural conditions really undergird our exposure to what's going on. And then of course, we haven't even talked about healthcare access and healthcare quality. I think there's one really good report that came out recently. They did an analysis of 195 countries around the world. What it found was that the United States ranked #1 in terms of preparedness for a pandemic. only ranked 84%. I think for most of us who are college professors, I mean, that's just a B. It's nothing to write home about. But the reason why they got the 84% is what's important. The United States was #1 in finances, but only scored 66% in healthcare access and healthcare quality. And part of what we're seeing with that lack of quality means that Black people are living in neighborhoods that have fewer hospitals, fewer urgent care clinics, fewer specialty areas. That means they have to go to longer places. So Melody's living in New York. If we think about New York, someone living in the Bronx trying to get to Manhattan for work or to try to get tested, it might take them an hour or an hour and a half with the restricted public transit schedule that they put in place. That's an example of a policy that was supposedly supposed to be a positive outcome to make people engage in social distancing that hasn't been. That's because social distancing is a privilege that oftentimes Black people can't do. And we see COVID-19 combining and colliding on the bodies of Black people.
Great. Just a quick follow-up question in terms of thinking about sort of a number of things in terms of this sort of intersection between preparedness and our healthcare infrastructure and the breakdowns between the two. If you could say a little bit more about that.
Yeah, so I think when it comes to healthcare access, I think it's a few things to note. Blacks, compared to whites, are more likely to distrust healthcare. Blacks are also less likely to utilize healthcare. A lot of that has to do with the structural location, but it also has to do with our very micro level experiences when we interact with physicians. Black people are oftentimes spoken to instead of spoken with. I think for a lot of white people and a lot of people who have means and affluence don't necessarily understand that. When they go to their physician, oftentimes they're having a conversation with them. Black people are spoken to when they have these encounters. And the way I like to think about healthcare encounters with Black people is like this. If I recommend a restaurant to you, or I come to St. Louis and you say, yeah, you should go to this restaurant, and I go and the service is bad and the food isn't good, and I say, okay, well, Keon recommended, I'm gonna try it again. I go back and the same thing happens. Well, guess what? We're not gonna go back. That's what happens to Black people with healthcare. And research shows, particularly for Black men, which we know when we look at data across age, gender, and race, that COVID-19, particularly the deaths, are really colliding on the bodies of middle-aged to older Black men from an intersectional standpoint, is that studies show that Black men who know about the Tuskegee syphilis study are less likely to utilize healthcare. But some of the research I've done with Dr. Abigail Sewell at Emory shows that Black people who actually attend Black Protestant churches are more likely to utilize healthcare. And one big policy solution that I've been pushing, and I've written a couple of these pieces at Brookings, people can go to FixGov blog and see these. One of the big things I've been pushing is utilizing Black churches and predominantly Black neighborhoods to do testing, triage, and treatment to try to actually increase the denominator. And we've heard other panelists talk about this. It's not just about how many people are positive for COVID-19, but how many people are actually getting tested from COVID-19.
Great, thank you. That's a perfect segue to Brian Smedley. I'll quickly introduce you and sort of make the connection. Brian Smedley is current Chief of Psychology and Public Interest at the American Psychological Association. His areas of research and practice include racism and health inequities, social determinants of health, healthcare disparities, diversity in health professions, applying the science and practice of psychology to the fundamental problems of human welfare and social justice. And Brian, I'll just jump right in and move to you. Thank you and welcome. So Ray really sort of started to outline some of the issues and challenges within our healthcare system. And I know that this is an area that you've done quite a bit of work. You are one of the co-authors of Unequal Treatment. So maybe we can start there with talking a little bit more about the healthcare challenges that we have, particularly as it relates to Black communities.
Absolutely. Thank you, Keon. Thank you for assembling this great panel. I want to associate myself with everything that this outstanding panel has already said. Until we come to grips with racism in all its forms and the way that it is expressed at structural, institutional, interpersonal, and internalized levels, we will not solve these problems. And what's happening in the course of this pandemic is that Americans are starting to see that our fates are truly intertwined. We cannot leave any communities behind because this means that we cannot flatten the curve. It is going to be extremely difficult for us to get through this pandemic if some communities are left vulnerable as a result of inequities that are manufactured by people and the structures and systems in this country. With respect to healthcare, your panelists have nailed it. People of color, particularly African Americans, receive a lower quality of healthcare, even when access-related factors such as insurance status and income are held constant. And so this is true across a range of healthcare services, disease areas, clinical services. What makes me worry is that we have another instance where a true inequity is about to occur, and we're watching it unfold before our eyes, and that's access to testing. Testing is a precious commodity at this time, and we have every reason to believe, because of decades of prior research, that people of color, particularly black and brown folks, are going to be less likely to have testing available to them for a variety of factors. Structural inequities, the distribution of testing currently favors more advantaged populations. The fact that biases and discrimination may enter into the equation about who gets tested in the first place may also enter into the equation, meaning that black and brown folks may have less access to testing and less access to some of the best testing that we need to ensure that we can do proper surveillance. And this relates back to the data issue that Dr. Goodman was talking about. Unless we know who's getting tested by race, ethnicity, gender, and other demographic factors, who's testing positive by demographic factors, who is being treated, who's hospitalized, who receives a ventilator, all along that process, we can expect to see inequity by race, ethnicity, and likely other factors as well. So we need to get a complete picture of the data. In the meantime, we need to be advocating for equitable allocation of testing resources. If black and brown communities are disproportionately hit, that's where the testing needs to be right now. We need to allocate those resources in those communities and do the surveillance to understand what will be the outcomes of that testing. But I also want to make another point that I hope we can inject into this conversation. Again, this pandemic, as tragic as it is, provides an opportunity, right? In every crisis, there's an opportunity. We have an opportunity to hold up a mirror to America, to help Americans understand how destructive social hierarchies hurt all of us, all of the isms, racism, sexism, xenophobia, homophobia. All of these kinds of issues will impair our ability to manage the pandemic because it foments social division. We see this playing out now in terms of elected officials and other leaders equating the virus to the quote unquote Wuhan virus or China virus. We know that there is a name for this virus. Dr. Brooks said the name of the virus, and we don't have to link it to a specific geographic region or country because that is only going to increase xenophobic attacks against people of Asian descent. We all need to be standing together talking about the importance of equity, social justice, and racial justice to get us out of this pandemic. That's why my colleagues and I encourage everybody on this webinar to tweet with us at #equity flattens the curve. #equity flattens the curve. When we can build a strong political movement for justice and equity as part of the pandemic solution, I believe we can help all Americans understand the importance of justice and equity so that we can have a stronger society coming out.
Great. Thank you, Brian. And you've been involved in the policy arena for quite a while. If you can maybe talk to us a little bit about some key moments or decision points that were missed in terms of addressing the pandemic sort of writ large, but also as it relates to vulnerable communities, African-American communities in particular.
Absolutely. So the facts are becoming increasingly clear that elected officials, particularly here in Washington, D.C., elected officials in the federal government knew about the virus back in January, February. WHO, CDC, others were tracking this. And it's clear that we need to separate the politics from the pandemic, but unfortunately they have become so deeply intertwined. We needed a clear public health response. We needed a clear plan to encourage physical distancing. It did not happen quickly enough, but thankfully many communities have responded. We also see, of course, a rising political crisis in that there are those who are opposed to stay-at-home measures, who are making their voices known and increasing risk not only for themselves and their families, but for all of us with their actions. And so we need to be very clear that leaders in all sectors need to condemn this kind of behavior. We need to condemn the racism, the xenophobia, the other destructive voices that could undo our attempts to manage this pandemic. Now, there have been some positive developments. Of course, there have been 4 pieces of stimulus legislation that have provided some assistance, but it's clear that there's many communities that still have enormous needs. Immigrants, for example, even legal immigrants are afraid to access some of the safety net services that have been expanded in the most recent CARES Act for fear that they would be denied legal permanent residency if given the new public charge rule. And of course, those here without documentation live in fear every day. And should they show symptoms, they may be reluctant to seek help out of fear of detention or deportation. So we got to put the science before the politics, and unfortunately, that has not happened yet.
Thank you so much for sharing. And I think it's a good segue to Rakaya Yerby. And Rakaya Yerby is a professor of law and a member of the Center for Health Law at St. Louis University. She's also co-founder and executive director of the Institute for Healing Justice. Her areas of expertise include racial health disparities, long-term care, direct care workers, civil rights law, and policy. Rakaya, what I want to do is sort of jump right into talking about some of the issues that Brian just mentioned. So he mentioned the recent stimulus packages that have been passed. How is that affecting healthcare workers?
Right, so thank you for including me on this. So when we look at the CARES Act, it not only impacts healthcare workers, but also those who are in essential jobs that are traditionally held by Black and Brown people. And so when we look at the CARES Act, the unemployment benefits, you have to work enough hours and be in a single place of employment, and that is set by the state. So that means that if you are a service worker, including fast food workers, hotel cleaners, agricultural workers, and home healthcare workers, that you are not covered under the CARES Act. That means that you go out every day, you provide essential services, but you are not provided with paid sick leave, you are not provided with coverage for health insurance. And so when we look at some of the direct care workers who are providing care to people in their homes, sometimes the most vulnerable, whether that be the disabled or the elderly, that they are not protected. So they have to continue to do their work. They're also not protected because they're not being provided with protective gear. We see some stories with home healthcare workers saying that they have tried to make masks out of paper towels and buy their own supplies to make hand sanitizer. And because they're not protected, in part because the home healthcare industry welded its power to make sure that it was exempted out. And this is nothing new, right? When we look back at the Fair Labor Standards Act in 1938, it was passed limiting the work week to 40 hours, applying the federal minimum wage, and also other protections. And exempted out of that are the same groups exempted out of CARES right now. It's the home health care workers, domestic workers, often the service workers, and agricultural workers. And for 70 years, they were not provided with protections, and we are continuing to see that now. So what I would say is that when we look at the relief funds that are being passed, it's just a continuation of structural discrimination, which is the power used by those in the majority, oftentimes rich people, to limit the advantages for poor people, which are poor, racial minorities, women. And what we see is that this is having a disproportionate impact on their health outcomes, meaning that they are the ones who get most affected. Those are the people that die. I think that we should look at the CARES Act, but also look at the movement by governors to open up their states and to force people back to work, right? And so we see in Iowa and Texas, them really moving to say that even if you are covered under CARES, if you decide not to go back to work because you are worried that you will catch the virus, if you're working in food processing plants where they have higher rates of infection, that you won't be able to receive employment benefits, right? And so it's this thought, you're using your power to further harm people who are powerless, but because you assume that for some reason they're lazy, they don't want to work, and they're not the most valuable people. And that's the wrong way to look at it, but it just shows how we replicate over and over again structural discrimination and the beliefs about hierarchy and what people are valuable. Because when you look at Iowa, Wisconsin, South Dakota, in particular South Dakota, half of the cases in South Dakota are from meat processing plants. That's because we are not requiring them under the law to make sure that people are healthy. And if we don't do that, then there will not be people to work, people won't be able to get their food, and we will not protect all the people that need to be protected.
Thank you. There definitely seems to be a lot of stories that are coming out across different sectors where where employees are reporting not having any kind of protected gear. Also, they are not asking or doing any kind of risk assessments of employees as they go to work. How do you see this as a problem and as one of the sort of important gaps, not only in CARES, but other legislation?
I would say that this is just a continuing example of, particularly in the United States, of us disempowering and disabusing workers. That when we look at the law really limits workers' rights, right? We have lots of laws and cases that have been passed to say, well, we cannot impose protections for workers because we feel they should negotiate on their own. We feel like it's a market system. And so we really care more about the bottom line, about capitalism, and about money. And so I see that this is just a continuation of those practices. I think that there have been lots of lawsuits challenging the fact that we're losing money because businesses are closed. And what I welcome and support is the loss of life from workers because they're forced to work in under circumstances that increase their risk of death. I think that also impacts our bottom line. If you're going to keep having workers dying, if you're going to keep allowing them to infect their families, you cannot do that without support. And that means that you pay them a living wage. That means that you provide health insurance. That means that you provide protective gear, whatever you can, or that you change the area where they're working so they are protected. And finally, that you provide them with insurance, survivorship insurance. I would say that to me, this is a great time to get behind the guaranteed basic income, particularly for essential workers. If you're going to force people to risk their lives so that our economy can go on, then you need to guarantee them a basic minimum wage that survives if they die and goes to their family.
Thank you. Let's turn a little bit to start talking about some solutions, and as well as we sort of think about this opportunity that Brian has mentioned to not only address the current pandemic, but also to address some of the systemic and structural issues that have been ongoing within U.S. society as it relates to health and healthcare. Dr. Brooks, you mentioned sort of this wealth and health gap in a number of different ways, and we see it playing out. So one of the issues that we've noticed in terms of looking at the geographic dispersion of some of these of some of the cases and mortality, even when we look in communities, for example, in Prince George's County, where Rashawn is, we see incredible mortality gaps. First, if we can sort of start there as an example of thinking about the health and wealth gap, and also thinking about some strategies to help bridge. And I'll turn to Ray, since I mentioned Prince George's County, and then I'll come to you, Dr. Brooks.
Yeah, so obviously in Prince George's County, I mean, it's the most affluent African-American county in the United States, but we see huge wealth and income disparities. And so if you actually look at a map of the county, which is 550 square miles, 1 million people, obviously everything doesn't fit everyone the same way. but what it becomes a great case study by which to interrogate what's happening with the zip code. So if you look in the southern part of the county and closer to Washington, D.C., as well as the northwestern part of the county where more Latinos are more likely to be located, that's where you see a lot of the cases in the county. This is because of all the things that we've already described. And I think when it comes to things we can do about it, because I think Prince George's County is also interesting because the county has been hardest hit in the state, but the deaths, the number of deaths in Prince George's County is similar to other counties in the state. And I think that's because there was a large testing facility put at FedEx Field, which is right in between a low-income area and an affluent area in Prince George's County, which is all predominantly Black. I also want to build on some of the solutions that were talked about. I mean, we talked about the importance of collecting demographic data, the importance of testing and triage in Black communities, and also having a guaranteed income and minimum wage. Minimum wage has not stayed on par with inflation since the 1960s. And it's estimated that it would take about $16 in the state of Missouri for people to actually afford a two-bedroom apartment. I think we really need to think critically about that. And we also need to have paid sick leave. As we heard, part of the reason why people are going to work sick is because they don't have any paid sick leave. And if they don't go to work, then they're not going to get paid and they can't put food on the table. So we need to have these policies put in place to actually do something about what's going on with COVID-19.
So from the NMA, National Medical Association's perspective, there are two areas that we're looking at. One is implicit bias training. People have inherent biases. It's human nature. Problem is, in a country where there has been 400 years of racism, there is endemic bias against African Americans. So the first step is in the broad community to accept that there is racism. Racism is real. You know, you like Michael Jackson and Michael Jordan, but when that patient walks in, all you see is a Black man. So we strongly believe that there needs to be systemic, comprehensive, implicit bias training. So you just wrap your arms around it. The other thing is we need more African-American doctors. Right now in medical school, approximately 4% of the medical students are Black. It's the same percentage as 50 years ago. It has not changed. So again, studies show that African Americans get better care from African Americans. It's just, I guess you go past that implicit bias part. So we do need programs in place to encourage African American children as young as elementary school, grade school, all the way up to college to enroll in and get involved in STEM programs. We at the NMA have been working to do that. But there needs to be a coordinated focus. There's a program at University of Maryland, Baltimore, where they have focused on that. And you have Kizzy Corbett, who's developing the vaccine that I can't wait for. And someone like Jerome Adams, our Surgeon General, both of those came out of that program. So when you look, there are a lot of diamonds in the rough. The Black community is full of Kizzy Corbett's and Jerome Adams. We need to mine those diamonds in the rough and cut them and make them shining diamonds and bring more of those as STEM students and then ultimately African-American physicians and then scientists. So that as a longer term strategy will help to address this issue.
Thank you. One of the things that's come up is this idea of, we've talked a lot about structural racism, structural factors, and systemic factors. That's quite difficult for people to wrap their heads around, especially given the pandemic that we have and trying to get people tested, into treatment, as well as protecting healthcare workers and essential workers. I'm gonna turn to Brian real quick. Addressing these structural issues seems, insurmountable in many ways. How do we reconcile addressing systemic issues as well as encouraging people to wash their hands as a health behavior challenge? And so we have sort of these things at opposite ends, but really what we're trying to do is address both at the same time in some ways.
That's absolutely right. I think it's important that, again, that we emerge out of this crisis seeing the opportunity, and the opportunity is to show people, as Dr. King said, our fates are deeply intertwined. And so first we got to get out of the pandemic, right? And so A number of the things that have been mentioned here are absolutely critical, but getting the data, getting testing where it's needed, expanding access to healthcare, expanding access to living wages, unemployment insurance, and all of the social safety net that we need. But then we also need a robust equity agenda that truly tackles the root causes of racial and ethnic injustice. Much of it is structural. Much of it is due to residential segregation and the economic marginalization and neglect of communities of color, as has been mentioned already. Our long history of redlining, while that policy no longer continues formally, in practice it continues because we have disinvested in Black and brown communities. We can't, we cannot allow this kind of man-made inequity to persist. This is behind the wealth gap that Dr. Brooks was talking about. We need to address school segregation, a major driver of K-12 inequality, limiting educational options for kids of color. The point here is not that it's necessary for people of color to be near whites. The problem is that white communities have hoarded the resources necessary for opportunity and success. And so that's why segregation remains a key problem. We got to address institutionalized racism, police departments that continue to terrorize communities of color, school systems with draconian school disciplinary policies that disproportionately affect Black and brown kids. All of these are part of a robust equity agenda that's going to be absolutely necessary, again, if we are to survive this pandemic and future crises that will come.
Thank you. I'm looking at some of the questions that are coming in through the chat and the Q&A feature, and a question related to this relates to vaccines. So one of the long-term solutions to dealing with this is the idea of vaccines. And how do we encourage underrepresented minorities, vulnerable populations to want to get the vaccine? Brian, if you want to start, and then we'll go to Dr. Brooks, or the other way around.
Yeah, that's a great question, Keon. So again, vaccines, once they're developed, it's going to be a precious healthcare commodity. And when you have a precious commodity, that's where the potential for bias and discrimination to, again, reinforce and deepen existing inequities. So we have to be very clear. Part of the challenge, of course, here in the US context is that these vaccines are being developed by private companies. They will be available to the highest bidder, and that automatically begins to eliminate Black and brown communities. So ensuring equitable access to vaccines has got to be a critical part of the agenda.
Okay, and I concur with everything that Dr. Smedley said, that Brian said. Two other issues. One is we need to be involved in the vaccine trials so we can have faith in the safety and efficacy. There is, due to historical legitimate concerns, some reluctance for the African-American community to get vaccinated. Though I work in the vaccine community, and I want to ensure the Black community that I would say get the vaccine. Okay, bottom line is that, you know, it's being developed very rapidly, which is great. I mean, it's fast. This is not the way vaccines normally come out, but we need it that fast, and the scientists, this is one where the scientists are handling it. So we need to be involved in the trials, and then messaging needs to be coming from the African-American community. Someone mentioned the churches. Churches are a great source of messaging for the African-American community. That equity piece, and it's clear, they've already said they cannot manufacture enough to get everyone all the time. So we need to be at the table when they make the decisions as to where it goes. Okay, if we're the ones most vulnerable, we're dying 2.5 to 5 times more likely, we should be the first ones to get the vaccine. So when those decisions start to get made, we need to be right there at the table advocating for our community.
Thank you. Dr. Brooks, you mentioned issues around health communication, health literacy. And I know that Dr. Goodman has done some work in this area. What are key strategies or messages that need to be in place, not only with communicating risk for the coronavirus, but also in terms of testing, as well as some of the solutions that we've been talking about?
So I agree with Dr. Brooks. I think this is where community engaged or stakeholder engaged, however you want to call it, research is really important, where we're bringing in the people that we want to take the vaccine and having them help us develop the message. I think I also want to emphasize and I said this before, that it's really important to invest in public health science. We're investing a lot in making this vaccine, but if we don't make the investments in public health, the people that are going to be designed to like disseminate the vaccine and get people to take it, having a great vaccine does us no good if Black people decide they don't want to take it. And so we really do need to make an investment in the part of our science that does messaging, that works with communities, that develops tailored messaging that they can believe in. And the other thing I will say is that the messenger is just as important as the message. A lot of the information that is best right now is coming out from CDC and NIH, but a lot of Black and brown communities don't trust the government. So sending them to a local health department for information or the CDC is not a trusted source. And this is where I think we really have to think about the messenger who is delivering the message.
And so in terms of thinking about the message, there's a question in Messenger, a couple of questions about vaccines in terms of encouraging African-American communities to get the vaccine. And Dr. Brooks and Dr. Smedley both mentioned that. So what have been ways or strategies that we've encouraged people to get vaccines? I mean, I'll use a personal story. I had a very long conversation with some members of my family over the Christmas holiday about the flu vaccine itself and their reluctance to get it. So if we have people that don't want to get the flu vaccine, how are we going to encourage them to get this new vaccine?
So I think some of this is going to be structural. The best ways that we've done vaccines in this country is getting children into school. So if you have a barrier that you need to overcome and the vaccine is the way you overcome that barrier, people are more open to it. That's why I think uptake of adult vaccines are not that high, because there's usually no gating. But if you need to get the vaccine in order to return to work, I'm almost sure NYU is going to make me get a vaccine before they let me go into any classroom. I will get a vaccine to get my paycheck, right? Like, I don't really have a whole bunch of options. I could be high and mighty about vaccination, but unless I have some real legitimate reasoning, NYU is going to hold my paycheck, right? And so I think that there's some structural things that we can do, but I also think it's more important that we develop a vaccine that has been tested in Black and brown communities, that we have data that we can take out to communities and tell them that it's effective, that we're clear about what the potential side effects are, and we're clear about if you're experiencing these side effects, you should seek help immediately. I think we really do, it's sort of like how the physical distancing works. If you give people the right information, they tend to do the right thing. And I think that's even true with the vaccine. I think the problem is whether or not we're gonna have the right information. If they test this vaccination on a bunch of well-educated white people, I don't wanna take it, because that's not who I am, right? And I don't know if those results generalize to people like me, right? And so I do think that we need to be involved in the testing, but we also need to be involved in creating the messaging. And we also need to be realistic about what the data is. If there are any side effects, we need to be clear about what those are so that people understand when they're taking the vaccine what they may experience. Because I think if we don't, then people are going to start to say, well, such and such took it to go to work and this is what happened to them, right? And so I think this is a case where we just have to be upfront and honest about the strengths and the weaknesses. Everything has a strength and a weakness, and give people real meaningful data that they can wrap their heads around.
Great. Keon, can I add one quick thing really there? So we did a study here where we just put posters up in communities of people in the community that got vaccinated against influenza. And when we did it versus communities that didn't, the communities we just saw a picture that said, I got vaccinated because I want to be around for my grandchildren. Studies showed that in those communities, there was better uptake of influenza vaccine. So also having the messenger, we keep hearing that, but just having people out there say, look, it's safe and effective. I believe in it. I got it, the vaccine. So that could also be helpful.
Thank you. So we have incredible assets within not only the African-American community, but broadly, but specifically within the African-American community in terms of not only churches, but fraternities, sororities, Mason groups, a range of them. If a couple of you could sort of speak to these assets and these social organizations and how we may be able to leverage them as a way of reaching Black communities to not only talk about the risk for the coronavirus, but also as relates to engaging them in strategies and solutions. Rashawn?
Very quickly to that, because I don't want to speak too often, but there's a group called the Divine Nine, which are all the Greek fraternities, and we're already talking about getting with them. I will be doing a presentation with the Links, which is another women's group out there. So you just have to reach out. I mean, there's a $1 billion industry up in, who is it from New York? Okay, it's called Madison Avenue. Man, we give them $500 million and you'd have everyone doing everything, okay? So we need to, the science. There is a science of communication. There's a science of bringing people together. So we can do that. I mean, we can speak to the sororities and fraternities, and again, the churches, and then the Black politicians. I mean, you bring all those people together, it can be done.
Yeah, I mean, I completely agree. I mean, essentially what these people are trustees. So they become gatekeepers to get people to a place where they're more likely to agree to do the vaccine. And we kind of went through the research there. I think also barbershops and hair salons. And Keon, you know that better than anyone with your large study in St. Louis. And so part of thinking through this, though, is, as we've heard from others, it's important that as trials are being rolled out, that people are transparent about what's going on and that testing is equitable. So we have to take a health equity approach to this. That means that if you're going to test in a predominantly Black community, and you're going to throw a drug there like they did in Detroit, or like French doctors were trying to say that should be done with poor Africans, those are the types of things that lead Black people to not participating in trials, to not getting vaccines. So we have to make sure that we are at the table when these conversations are happening, because if we're not, one thing we know from Shirley Chisholm, if we're not on the table, we're on the menu and someone's eating us for lunch. So we have to bring a folding chair. That folding chair is our voice to our policy makers. I work in these spaces on Capitol Hill and in state politics, and we have to be there. There's a great app called The Countable. You can download it on your phone. Countable. It allows you to instantly connect with your elected officials at the state and federal level. So part of this engagement means if we're going to do something in a predominantly Black community, we also need to do it in a predominantly white community, and then be transparent, as Melody was saying, about what happens with those particular drugs to get us on board to get the testing. And the messenger becomes very, very key.
Great. Rakaya, you wanted to speak a little bit about policymakers and the role of engaging with policymakers.
Yes, and I know I will be quick because I see our time is running out, but I just wanted to highlight a question in the chat that talks about racial justice and working with policymakers. So Keon and I are on a project looking at cities and counties working on racial equity and actually using it to change their policies to address some of these issues. And so I think it's a good time to actually go in those communities in Wisconsin and Milwaukee and Washington and various places in Iowa to actually go in and talk about how they've been working towards racial justice, but this is just one example of how we need to move further and connect the dots, right? It's not just about working in racial equity in terms of hiring people, but it's also how that is connected to their pay, paid sick leave, and their overall health outcomes. And so I think that is important. But furthermore, I think that it's not just a racial justice issue, even though it is, right? It's a justice issue just generally. Here in St. Louis, we just look at it as definitely disproportionately impacting African Americans, but then that impacts all of us, right? Because that means that the person who's working at the grocery store, who is a Black woman, perhaps with a pre-existing condition, can give it to you. So you can be impacted. And so we need to think about the ways that we need to work together to improve our city, our county, and our area. And what does that mean? That means hearing my voice to talk about the ways that it impacts me differently. I love how Dr. Goodman talked about it's not just about the density and where we live, but it's the density and where we work. And so those are things that we need to listen to workers about to actually address. So I will put in the chat just a link to our study on racial equity. And if there are more questions, please definitely let me know.
Great. Thank you so much. And I do want to take this time to thank each of the panelists. Brian Smedley had to get off. Everyone is extremely busy, and I want to thank you for giving us an hour of your very important time. We're going to conclude this webinar discussion. We have our information and their information here on this last slide, and also want to announce the next webinar in this series on healing justice approaches to community and self-care, Tuesday, May 5th. That will be facilitated by Kira Banks. Again, I want to thank everyone for their time and for their contributions to the discussion. You can reach each of the panelists at their social media handles, as well as you can find their emails on their respective university or institutional sites. As we work towards addressing and stopping the trend of this pandemic, let's work to addressing the health inequalities and the systemic and structural issues that have caused them for a very long time after the pandemic and during this pandemic. Thank you so much for your time, and I'll conclude here.
Thank you.
Thank you all.
Thank you.
Thank you.
Thank you.